Hi, my name's Rachel Hiller. I'm co-director of the UK Trauma Council and a professor in child and adolescent mental health at UCL. I'm joined now by David Trickey, who's a consultant clinical psychologist and my co-director at the UK Trauma Council. And we're going to be having a conversation about what we think commissioners and service leads should expect in terms of evaluation of service provision. So David, first up, in a general sense, what do we think commissioners should be expecting when they're commissioning a mental health service?
I think commissioners should expect, possibly even demand, information about output and outcome. And what I mean by that is, first of all, output. How many children and young people are being referred? How many of those referrals are accepted? And why are some of them not? What are the reasons for not accepting those referrals? Of those that are accepted, how many are assessed? And if there are any that haven't made it from acceptance to assessment, why not? Mm-hmm. Of those children and young people that are assessed, how many are then offered an intervention? And for those that are not, why not? Mm-hmm. For those that are offered, how many take it up? And those that don't take it up, why not? And of those that take up the intervention, how many make it through to the end of what they would think of as a reasonable amount of intervention? So those numbers all the way along, and working out why some of the young people are not making it all the way to discharge, if you like. I also think people should expect to have the demographic information of those referrals so that they can make sure that they are offering a service to the population as reflected in their local looked after population. In terms of outcomes rather than outputs, first of all, are services using reliable, valid measures for measuring mental health outcomes? And then, what sort of level of distress or functioning, broadly speaking, do children have when they arrive in the service, and what about when they leave the service? And what's the difference there? So I would be wanting to know, well, how distressed, how much are the children and young people struggling when they arrive, and how much are they struggling when they leave? But also when services present that data, I want to know how many of those young people have had that particular tool used. Because there'll be some children and young people where actually it's not appropriate to use a questionnaire or whatever the tool is, but for most of them it should be. So when we look at the outcome data, the before and after scores, most of the children and young people should be in that data. And I would want commissioners to be asking, what's the percentage there? What percentage of children and young people that you've worked with are we actually seeing in those graphs?
And I wonder if we can talk about the SDQ now, the Strengths and Difficulties Questionnaire, because that is the tool that is used with children in care. It's in England, I should say. It is part of the mandatory reporting to the Department for Education. So it will be familiar to a lot of people watching this video. Usually it's Carer Report SDQ that's collected by the local authority and used for Department for Education purposes. The SDQ, I think it's safe to say, has a bit of a bad reputation amongst services, and I think that's partly driven by the fact that it's not necessarily being used as it was intended. The SDQ is a nice little screening tool, but it's just meant to identify where further assessments might be needed. And certainly one thing we know about the SDQ from research is that it also misses large numbers of children that score highly on, for example, post-traumatic stress screening instruments. So it can miss as much as 50% of children that would be in the clinical range on a PTSD screening tool. So I wondered what your thoughts were thinking about how local authorities work with mental health services around the role of the SDQ, how it can be thought of in a way that might be helpful, and what other types of screening tools services might consider using with young people in care.
I mean, it's interesting, isn't it? The Strength and Difficulties Questionnaire, the SDQ, 25 questions, very broad measure of lots of different types of problems. And as an overall, almost a population level measure, it's not so bad. You know, it gives you a very, very rough idea of the sorts of level of distress in a particular population. And perhaps if 90% of children coming through a CAM service were doing the SDQ before and after, then we'd have more information about whether this is useful or not. The truth is that very few people manage to get that kind of level of reporting. So on a broad level, the SDQ is okay at kind of measuring broad level, wide-ranging distress, difficulties in functioning. But in terms of actually specifying what are the problems here that we're going to try to help the young person with, I'm not sure that it's specific enough. And there are other measures that would be more useful for that particular job. So
there, are you referring there to kind of mental health disorder specific symptom screening tools? That might be for post-traumatic stress symptoms, it might be for depression, anxiety symptoms, conduct symptoms, and elsewhere in this module we provide more information about where you can find those measures. But it's one thing I think it's worth highlighting is that those measures already exist. There's a large range of free, well-validated, standardised mental health screening tools that are not about making a diagnostic decision, but help to understand the needs of that young person as an individual, and then hopefully, if used correctly, to follow up whether there's change during treatment.
Absolutely. So those specific measures for those specific different types of mental health problems, I think can do two things really well. They can help to measure before and after, which can then show to the commissioners that it's effective or not. But also they can help the individual clinicians work out, well, what's going on for this particular child? What can I offer? What's going to be the most useful thing? And it might be that we're missing things. Sometimes when I use a questionnaire, it picks up things that I had missed as a clinician. Yeah. So they can be really useful. They're not perfect by any stretch. It's not like a blood test that tells you exactly what the virus is and therefore exactly what medicine you need. But they do give you a rough idea, and they're valid enough and they're reliable enough to help me as a clinician, but also to help those commissioning the services to know whether it's any good or not.
Yeah. And one of the things we sometimes hear from commissioners is that they get pushback from services that introducing these kinds of measures somehow dilutes their clinical expertise. And elsewhere in this training, actually, there's a whole module focused on what we mean by evidence-based practice and how research evidence and clinical expertise and lived experience expertise actually sits perfectly together and should sit together. And I guess when we're talking about screening tools, we're really talking about a way to support clinical decision-making. It doesn't take away clinical decision-making. For children in care, we know that some will underreport their symptoms. So they will say, oh, I'm fine, none of this applies for me. And the adults around them might know that that's probably not true. So certainly there's still a huge need for clinical decision making there, but we want to support that with these evidence-based tools.
Exactly. I mean, there will be some children where the first time you use a measure, they say, I'm fine, and say nothing. And then when you finish working with them, they've got to know you now, they trust you now, they're able to share a bit more. It might look as if their score's gone up.
Yes. Yeah.
But when you are using these measures with most of the children you're working with, yes, there'll be some like that where the score's gone up. But overall, we would be expecting and wanting the scores to come down on average.
Yeah. And that's an interesting and I think really helpful message there, is that children in care, like all young people, you will have some that don't want to do measures at any point. You will have some that don't think they're right for them, or who get more comfortable and therefore symptoms go up, as you're talking about. And that is tricky to manage as a clinician. And it's tricky to know what to do from the commissioning level for that. But one of the messages for me is that we don't throw out all of the evidence base because a few young people might not want to do questionnaires, that our baseline should always be that we offer what we know is best evidence practice. And here that is using validated screening tools and allowing young people to say no, and that being okay, which is what we would do with other groups of young people as well.
But also, are they making a well-informed decision to say no?
Yeah.
Do they understand when I say, oh, can we do this measure? And they say no. Do they know what I'm talking about? Have I said it's just 8 questions, but here they are. We don't even have to do it today, but I'll leave it there in case you want to look at it. It would really help me. Do we explain to them why we want to do it? This will help me to understand the level of your distress and then to work out what I can offer. It will also help people that are paying for this service to work out whether it's useful or not. If they still say no, fair enough. It's absolutely their choice, but I want to make sure it's a really well-informed choice.
And the same goes for offering treatments.
Absolutely.
Are we making sure we're being really clear in a very accessible way to the young person in front of us, that they understand why we're making certain decisions and why we're making certain offers that we think are the best evidence for them, and making sure if they say no, it's really a no, and that they can say no, that's important, but that it's a no that is a properly informed know about why things are being offered to them.
Exactly.
So taking a bit of a step back, why is it important from the commissioning side to expect a service to evaluate themselves? Why should commissioners not just be expecting that, but actually demanding that services do evaluate what they're offering?
Partly it's because they're using public money, and we don't want to be wasting that public money on something that we don't know whether it works or not. And partly it's because children and young people deserve the very best service we can provide them with. And these measures will help us to make sure that's what they're getting. It will help individual clinicians, but it will also give a rough measure to those commissioning the services to whether this is actually effective or not.
In terms of services evaluating themselves, one of the concerns that can potentially go back to commissioners is that services might feel quite threatened by the idea that they have to evaluate, that they are working with young people that can have very complicated lives, that where they're not just sitting down and doing 10 sessions once a week and seeing symptoms change dramatically. It can be a more complicated picture than that. You'll know that in your work as well. And that can be used as a reason to say, well, we don't think using those kinds of measures and tracking change is appropriate for our services. How do you think commissioners should manage those kinds of statements?
I still think it's important that people are measuring outcomes in a valid, reliable, quantitative way. And yes, these may be very complicated situations. The young people may have pretty complex problems. The placements might not be stable. So we're not expecting all of the children and young people to have much lower scores at the end. But broadly speaking, on average, we would expect children and young people to be doing better when we say goodbye to them than they were when we said hello to them. And I don't think services should be afraid of showing that. 10% might get worse, but that's real life. Broadly speaking, they should be doing better at the end than they were at the beginning. And if they're not, well, let's look at that. And perhaps it is the measure, but let's get 100% of young people filling in these measures before and afterwards, and then see. And let's then think about why the measures may or may not be valid.
So partly there, from the leadership perspective, it's also about cultivating a culture within services where it's okay to look at data and sit with things not being perfect, that some young people might not get better, some will, some might get worse, of course. But certainly from the commissioning lens, if there's a service where large chunks of young people are getting much worse, we need to know that. The service need to know that. The service need to be able to have the opportunity to reflect on what might be going on in their service and make changes. And we see this happening quite well in the adult IAPT system, which of course is imperfect in many ways as well, but certainly much more advanced in terms of conversations around, we looked at our services data and we realised that half of our adults with complex PTSD weren't getting better in our treatments. So we looked at who they were that weren't getting better, why that might be. We offered more sessions of trauma-focused CBT or the treatment that they were using. We offered a stronger focus on this. We offered whatever it might be. And they're using that data really in a very non-judgmental way to improve what they offer and reflect on what they're offering. And I wonder how you see that working in the child mental health space, especially when it comes to children in care that might be receiving mental health support in social care, it might be in CAMS, it might be in the voluntary sector. Should all of those groups be using these screening tools, or is it more applicable to some areas than others?
My personal view is that all those services should be using these screening tools for most of their children and young people. If we can get to that level, then we will learn much more about the data, about what's working, what isn't working, including whether the screening tools are working. Let's get a high level of return rate on these measures, and then we'll have some decent data to really be able to do something with. But at the moment, I think there's too many assumptions that this isn't useful, it's not going to be relevant, it's going to be unhelpful. And I think those are unfounded assumptions. And I think we should explore that in more detail.
Another thing that commissioners might hear from services is that they've developed their own screening tools because they don't think the available ones are adequate. And how do you see that? Is that an issue from your perspective? Is there space for developing your own screening tools?
I don't think there's the need to. There's enough reliable and valid tools out there that will measure different aspects of a child's mental health. I don't think you need to invent something new. And if you do invent something new, you're going to want it validated properly. So do these services really have the time and the resources to do the research necessary to validate their own tools? If they do, fantastic. But how come?
And very unlikely. To validate a screening tool is such a large process of huge sample sizes.
And there's a choice out there, There are lots of different measures out there. And if you don't particularly like that one, well, look for another one that's still valid and reliable and is going to be useful.
Yeah. And then another piece of that is, so a message there really for commissioners to be aware of is that services should not be developing their own screening tools. We would see that as a potential red flag that the service is not offering evidence-based practice because, as David said, there's so many freely available standardised screening tools for them to pick from. Services can then also say that they feel like it's too deficit focused, that it's not focusing on the strengths of the young person or a holistic assessment of the young person. When you're using these screening tools, how do you ensure that you're still doing holistic or strengths-based assessments with young people?
Well, sure, most of the measures will focus on difficulties, but that's the business we're in. They're coming to a mental health service because they're struggling in some way. So it's okay to assess those difficulties. And in fact, what we're being commissioned to do is to make those difficulties less. So I would lean into the idea that a lot of those measures are problem focused because that's why they're coming to see us. That doesn't have to be my whole assessment. Whenever I do an assessment, I want to know, well, how have you got to this point? What are your strengths? What are your interests? What is helping you to survive in life at the moment, despite all these difficulties? So in fact, those measures most of them may be focusing on difficulties, but that's okay. That doesn't mean the whole assessment is deficit focused.
So to finish up this conversation, there's been some really helpful key reflections from your perspective as a consultant clinical psychologist and someone that uses these kinds of tools with children in care and other young people that might have what we consider complicated or complex needs or be living in complicated situations. So some key messages are that commissioners should expect and really should demand that services that they're paying money for are evaluating the provision so we can make sure that we are actually helping the children and young people in those services. We can do that in a non-judgmental way, and that's really important, of course, because our frontline professionals are working very, very hard to help children and young people. But that we can't shy away from evidence-based practice and that these screening tools should sit alongside qualitative feedback from children and young people. The qualitative feedback is very important, but it shouldn't be the only way that we evaluate our service provisions. It's not a robust way to evaluate provision. And within this module and elsewhere in the training, we talk about this in more detail, and we also provide checklists so you can support your services to understand how they can evaluate themselves and how they can use these tools to reflect on their own practice.